Clinical vocabulary has moved from the hospital into the home. Words like trauma, bipolar, ADHD, and delusion saturate social media feeds. This is semantic diffusion. Technical terms stretch horizontally to cover ordinary human distress, normal exhaustion, and everyday personality quirks. These culturally stretched definitions eventually cycle back to the doctor's office. This is semantic feedback. Patients arrive using these medicalized terms as concrete self-diagnoses to explain their pain. By the time an assessment begins, the person's experiences have already been filtered through online symptom checklists, advocacy narratives, and algorithmic feeds. The clinician is no longer assessing a blank slate. They are negotiating with a pre-packaged digital identity, which makes the diagnostic process a highly subjective and contested space. To see why this makes psychiatry so vulnerable, compare it to physical medicine. When a patient walks into a hospital claiming they are having a heart attack, the cardiologist doesn't rely solely on their description. Comparing diagnostic pathways. On the left, cardiology follows a linear track using objective physical biomarkers to verify a patient's claim. On the right, psychiatry lacks physical biomarkers. Instead, this complex network of language and inference must perform all the adjudicating work. When technical terms lose their precision, the primary tool psychiatry uses to observe and understand the mind begins to fail. The drift toward low resolution accelerates when these blurry words collide with a constrained healthcare system. This triggers semantic compression, where institutional pressures force clinicians to reduce complex reality into rapid labels. In high-resolution practice, clinicians climb an inferential ladder, from raw observation to detailed description to final classification. But on the right, service pressure crushes those middle layers. Observation is forced straight into a rapid label. This is how a symptom like rapid speech is instantly branded as mania, or how contextual life distress, like debt or a severe loss, is immediately coded as depression. The administrative need for speed transforms provisional hypotheses into hard facts, treating a human story as a simple billing barcode. Once that compressed label enters an electronic health record, it hardens. This visual shows the fluid, nuanced form of human perception being forced into rigid diagnostic codes, permanently locking into the record as semantic sediment. This digital sediment prejudices the next clinician who opens the file. It creates a confirmation bias where the historical label dictates what the doctor attends to in the present encounter. This leads to the reification trap. This diagram illustrates the error of confusing an artificial map for the complex reality of a patient's terrain. A provisional category is suddenly treated as the biological cause of the symptoms. Notice the inferential inversion arrow. The label is treated as the root cause. A person lacks energy because they have depression, ignoring the sleep loss or trauma that actually formed the pattern. The classification becomes a circular explanation. The digital record transforms a doctor's personal interpretation into a permanent administrative fact. This clinical judgment effectively rewrites a patient's history, dictating their future access to services and social support. This linguistic failure leads to biological essentialism. A loose label leads a clinician to automatically assume a brain disease is present, prompting them to immediately prescribe medication. The identity-level damage is direct. Ordinary human reactions, grief, ambition, or spiritual longing, are interpreted entirely as symptoms of a lifelong disorder. The label consumes the individual. The symmetrical error is therapeutic nihilism. A clinician becomes so skeptical of these flawed diagnostic categories that they cynically withhold effective, potentially life-saving treatments from people who genuinely need them. Both extremes erase the individual person. Whether the system relies on a rigid category or an unyielding skepticism, it fails its primary duty of care. The alternative is a return to high-resolution psychiatry, which requires us to reconstruct the discipline's linguistic instrument. This demands observation before inference. Clinicians must rigidly separate what is actually seen from what is assumed. It requires phenomenology before nosology. The nuanced structure of a patient's lived experience must be explored fully before it is sorted into any box. Clinicians find the most utility by asking why this specific state is occurring in this specific person at this specific time, moving past the search for a standard billing code. A diagnosis functions best as a provisional map, or a scalpel, a tool for careful intervention rather than an absolute verdict. Sharpening this language ensures the clinical encounter remains focused on the person's lived experience, protecting them from being lost inside an administrative category.